Good morning, everybody. It's wonderful to be here back in the old alma mater. Particularly like to welcome my classmates from 1980 who have come here to support me in my hour of need. So this is the North American neurosurgeon's viewpoint of Irish general practice. I have a number of Canadian and American friends in the class, so I'm not saying whether this is an American or a Canadian. Before I start, there was a classmate of ours, Fergus McKegney, who passed away 3 months ago. I'd like you to look at the photograph. That describes Fergus. Always relaxed, arm folded, never took life seriously. But above all, he was a wonderful general practitioner. His patients really admired him. He was a great musician, golfer, fisherman, raconteur, bon vivant. But above all, he was a family man. He had 5 children and he adored those. But to spend 5 or 10 minutes in the canteen with Fergus up above having a cup of coffee, you just came away feeling better about everything. So again, Fergus, you're not here, but you're here with us in spirit, and I can feel you here today. This is Ratangan Medical Centre. This is where I practice. One of the things that has sustained me and continues to sustain me in 45 years of general practice is we do a lot of teaching in the practice. We teach postgraduate university students from the University of Limerick. In their 3rd year, they go to hospitals for 18 weeks, and then they come to a general practice for 18 weeks. So in January this year, my new student came to me. So within 2 minutes of coming into the practice, Dr. Boland, sir, how are you? When am I starting? What am I going to do? And I says, hold on a minute, there's a certain rhythm to GP, and I don't think this is going to work. So the more he talked, I thought, you remind me of someone. I thought, have I met you before? No, I said, you have some of the characteristics of one Donald J. Trump. So I said, this isn't certainly going to work. So he was all over me like a rash. And I said, listen, can I just ask you 2 things? Can you just take 30 minutes off now? Don't write me an essay, but just write me bullet points. What do you think I do on a day-to-day basis in general practice? And what do you think general practice is all about? So this was going to give me 30 minutes just to get my head together. So I put him in his room. 2 minutes later, he came back to me. He says, Dr. Boland, sir, I have the answer of what you do. So the answer was, he says, a day in the life of a general practitioner, a job description. Well, sir, he said, you write prescriptions all day long. You refer every patient to hospital OPD for a consultant opinion. And he said, anyone who can't wait, you refer them to A&E casualty, and any patient that can't wait to be seen in OPD, you send them to casualty straight away. I thought, Jesus, this is going to be a long 18 weeks. This is going to hasten my retirement into general practice. And again, this is what he told me general practice is all about. He just went in, he printed a page from Wonka, and this is their definition of general practice. So I said, listen, come here, I said. I had a quick discussion with the student neurosurgeon. Now, the student neurosurgeon says, what are you going to be? He says, oh, I'm going to be a neurosurgeon, sir. And I said, yeah. I says, oh, that's operating on the brain. No, sir. He says, I'm operating on the posterior fossa. And I thought, what's in the posterior fossa? Oh, I said, that's the cerebellum. No, sir. He says, I'm going to be a vascular surgeon. And my speciality is going to be dealing with aneurysms at the bifurcation of the 2 vertebral arteries and the basilar artery. He said, sir, if you want my phone number, if you get an aneurysm there, you have me on speed dial. So anyway, I said to him, listen, I said, this is a typical day in general practice. And I do all these in a 15-minute consultation. I manage CNS problems, ENT, respiratory, GIT, urology, locomotor, cardiology, mental health issues, minor illness, women's health, men's health, gender euphoria. I said, this is general practice. It's really varied and wild. And I said, the competency domains of a GP. One, I deal with diagnostic uncertainty. Every day I deal with diagnostic uncertainty. You've got to be comfortable doing with that. General practitioners have to have good communication skills to listen to people. Again, they need their clinical knowledge and expertise to be up to date. They need empathy. They need a holistic approach. Again, we need conceptual thinking and problem solving. And again, I said, listen, there's a certain organization and management of resources in general practice. Again, there's professional integrity. Again, coping with pressure. So dealing with 15-minute consultations and lots of information coming into the practice. And again, I have to manage a team, motivate and support a team. time. So I just went through them. I said, look, I'm going to talk to you about practice organization, computerization, digitalization, and coding in general practice. General practice is a business. And I just picked one subject for him, gestational diabetes. And then I said, look, I'm just going to tell you a bit about Pandora's box and serendipity. My good friend Albert Einstein. Einstein's definition of insanity, continuing to do the same thing the same way and expecting different results. Unfortunately, 3 months ago, I was hospitalized for the first time. I spent a week in hospital. I had severe cellulitis and tenosynovitis. I went to a regional hospital for orthopedics, 6 orthopedic surgeons in there. Absolutely top-class medical care. Couldn't fault it. But one of the things I noticed in the hospital was everything was a paper transaction. They were all paper charts. They were all paper records. And again, this is the appointment letter that came out to me. And luckily, it arrived for me the day before my appointment, but before my appointment was due. So this is our practice in Rathangan. So if you come into the front door and practice in Rathangan, you're now approaching it. So you can see the reception and the waiting room. So again, nobody has to come into reception. It's all digitalized. They just attend at the patient check. This is our check-in screen. Very simple. Are you male or female? What month were you born? What day were you born? And then your day, it just comes up. Thank you, Finbar Boland. You've been checked in for an appointment with the nurse. So just a bit about computerization, digitalization, and coding in general practice at the moment. Computerization and digitalization is the best medicine for a sick healthcare system, which we have in Ireland. Professor Martin Curley, who's Professor Martin Curley? Professor Martin Curley was appointed HSE as head of computerization. And this is his final statement. Patients are at risk of adverse outcomes and even death as a result of lack of information and communication in the health service caused by poor IT infrastructure. And that is 100% true. Martin Curley, he resigned after 4 years. He'd had enough. He said trying to reform the HSE was like trying to climb Everest. Cited frustrations. He said that no vision or anything. €200 in 2000 had been given for IT infrastructure. No idea why this money hadn't been spent. Again, another Dr. David Tansey said in Ireland we need a national universal record system, national patient identifier, and a national system for radiology and bloods. General practice is fully computerized. I am ready for all this. We were ready since 2000 for all this. But hospitals continue with an archaic paper system. So the three changes I've just described would improve the safety. Anyone know what country this is? This is Estonia, okay? And I think, the Baltic countries, they're a bit behind us. We're Western civilization and everything. Estonia made the decision 15 years ago to digitalize everything. So 99% of their health data is nationalized. So this allows a complete integration of general practice, community care, everyone. So if someone sees a patient in general practice in Estonia, the records are available in the hospital, the records are available anywhere. Again, Estonia is a EU member state. And again, our public hospitals, the record systems are siloed across different services and archaic reliance on paper throughout the system. This is a month ago. This is genuine. So 63-year-old, I call a 63-year-old patient into me, right pleuritic chest pain, examination is completely normal. Straight away on my computer system, I can see past medical history. She's ischemic third nerve palsy. She's hypertension, obesity, gout. She's antiphospholipid syndrome. Totally at risk for pulmonary embolus or thrombosis. So again, I said, this is an urgent referral to A&E. It's all emailed in, all her medical records, past medical history, drug therapy and everything. And again, that's done in 15 minutes. And again, that's done and dusted. I've moved on to the next patient. I have sorted that out. I'm delighted. Okay, 15. Friday. Hi, Dr. Boland, SHO and ACE here. Many thanks for your referral of patient X with concern for a PE. Your clinical suspicion has been confirmed, but thankfully she remains stable. We were hoping for any correspondence you may have in regards to her diagnosis of antiphospholipid syndrome. Now, this was made in ACE Hospital, okay? Patient herself was offered this. Okay, thanks for your help. So I rang the SHO and she says, Dr. Boland, I spent 2 hours in medical records trying to get her chart here. Can't get her chart. She was seen by a haematologist in Tara. I was on the phone to medical records in Tala. They said it normally takes 5 days to get back to you. So this is 2 days later. She's in our hospital system. They've diagnosed her with antiphospholipid syndrome. they can't find any medical records. I just went into the file, got the 2 letters and emailed it straight out to her. A crossroads that you're all familiar with or should be familiar with. This is a city with 14 million people in it. This is Wuhan in China, which is certainly on a record from five years ago. Okay, this is when COVID-19 came calling. My good friend Winston said, if you have a crisis, never let a good crisis go to waste. So what we did in our practice, we immediately increased our health and safety. But because we were fully computerized, immediately all our prescriptions went straight to the chemist, all our social welfare certs, anyone phoning in, they could instead do that by email. Our practice website was updated. They now could pay through our practice website. We set up COVID vaccination clinics. Now, we didn't have to ring everyone. All we did was group texting out to the patient. So anyone over 70 just pull the records with one click of a button on the computer. He sent all this out via text message, and then they could book online for their clinics. And this is where IT is at in general practice. The importance of coding. Is coding important? It is, because it allows us in general practice to identify specific diseases, hypertension, hyperlipidemia, cystic fibrosis, whatever you want. All our patients are now coded. So if COVID-19 comes again, what we can do is just print a list of our patients who are over 70, have diabetes, have hypertension, and they're all ICD-10 coded. General practice. General practice is a business. We provide quality health services for profit. It's a service industry. We provide services 24 hours a day, 7 days a week, 52 weeks of the year. The services are provided locally, which is convenient to the consumer patient. It is a very personalized service, and it's a continuous service from the cradle to the grave. Again, the GP today, most are in partnership, have administration staff, have practice nurses, have office equipment, have computer records. They deal with thousands of blood investigations, chronic disease management, everything like that. The premises, we have a premises, have a car, journals, professional organizations, medical defense union, medical insurance, public health, safety, liability, insurance, pension policies, everything like that. Practice premises, you need a safety statement, you need access and egress, safety procedures within the practice, supervision duties, record system are fully computerized. So if someone moves to Australia, we can email their records. I can email any records to any hospital, only a lot of them aren't computerized. We have a specific complaint system. We have systems at work. We have business management systems in the practice. Again, financial management, we have professional staff, collect debts, pay outgoing, pay staff, mortgage, rentage, pay off equipment. So the GP today, he's a regulated professional, he's employer, he's a business fund manager, he's a data controller, he's a care coordinator, he's a record manager, he's an educator. Just going to talk about gestational diabetes. What is gestational diabetes? Gestational diabetes is diabetes that occurs in pregnancy. Is it important? The risk is increasing and the follow-up is inadequate. 1 in 2 women with gestational diabetes will develop diabetes mellitus within 10 years. The risk is highest within the first 5 years. Is this important, diabetes mellitus? Professor Thompson and Beaumont did a study. When someone develops diabetes mellitus, they have the same chance of having a myocardial infarct or a stent put in as someone who is just coming out of CCU with a stent or a myocardial infarct. So this is critical. Highest risk is in the first 5 years. Very simple to treat: physical activity, healthy diet, and promotion of breastfeeding. And recruitment of people with gestational diabetes should start as soon as the lady has had the baby, because now she's motivated in relation to her health. My 2 practice nurses, Roisin Doog and Mary Ramsbottom. Okay. What they provide in relation to gestational diabetes, they provide yearly structured, personalized education, support, and follow-up. They provide consistent advice and care. So if my patients go to a hospital clinic for gestational diabetes, they may be waiting an hour They're given an appointment. It mightn't suit them. They may be seen by a different diabetic nurse. In our practice, they're seen by the same nurse who will give consistent advice. They have a personalized relationship with this nurse. They get yearly bloods done. They get an ECG done. If the nurses need to liaise with me, I'm there on hand. We encourage people, they're encouraged to keep up to date with their vaccinations. Is that important for them? Hugely important. And they're part of the chronic disease management. Again, any lady who has a baby, they're due 5 vaccinations in the first 13 months of life. So the mother brings them in. So this is 5 opportunities in the first 12 months that they've had their baby, that the nurse is there to give them consistent advice about gestational diabetes, what their risk factors are, and everything. Again, the cycle of change. So if the nurses have someone coming into them who's just after getting divorced, their husband's had an affair, they've lost their job, they're getting redundant. No point in talking about weight loss. But if they come in, they've had their second baby, they're now motivated. I want to be around for my child. This is where the cycle of care comes in. And this is where our nurses are able to target those ladies and just offer them consistent advice and everything like that. Dr. Barry Boland, 1986, qualified in 1980, put a lot of work into my career, went over to Scotland, got fantastic training in Scotland, and then ended up vocationally trained. Was I competent in 1986? Yeah, I think I was competent. Was I confident in 1986? Yes, I think I was confident. I don't like saying this because my picture could appear for anything in the Irish Medical Times saying, is that idiot who gave a lecture in the College of Surgeons? 2025, am I competent? Yeah, I think I'm still competent. One of the things that I've done is just through the education of the students, it's kept me up to date. Am I confident? Yes, I am confident, but you can see there's a question mark here. Pandora's box and serendipity. If I was an examiner here in the College of Surgeons examining third med students, if I said, listen, I have a 51-year-old man with lumbar back pain and he has a PSA of 922, what do you think the diagnosis is here? Upper limit of PSA is 4. Well, I'd expect him to say, this is a man with prostate cancer, probably metastatic, and he needs to go to hospital. You are not going to miss that in general practice. Okay? The way that consultation evolved was, his wife is a patient of mine and says, Dr. Boland, will you see my husband? I don't like seeing other patients. I don't like seeing other patients' GP. I like to see what I see and diagnose it. And so that's the way I was thinking when this man came into me. So he came into me and said, hi, Dr. Boland, I have back pain for a couple of months. I examined him, general examination, no weight loss, nothing else. Did a general examination, full back movement, everything. And I was about to say, look, this is soft tissue pain, call it what you want, facet joint. And I was going to send him home. And just as he was getting up to leave, he says, oh, by the way, Dr. Boland, I'm not sure why this is important, but two of my brothers under 50 have had prostate cancer. Jesus, sit down, we'll do a PSA on you. Otherwise, he was gone out the door. So that's how I picked up prostate cancer in that man. He was nearly gone out the door. Next thing, 50-year-old man comes into my registrar with thoracic neck pain, and my registrar said, Barry, could you come in and have a look at this man? So I came in, I knew him well. Doesn't appear in the surgery. That's the first thing, never appeared. Neck pain, I said, any injury, no injury, any temperature, anything like that, nothing, just pure neck pain. Examined his neck, nothing to find. And I was wondering what I was going to do. And at the end, I looked, he hadn't had bloods done, and I said, we'll do his bloods. Did his bloods, CRP comes back at 230. Now I ring him, I get him in, I go through him like a fine comb. I can't find anything on him. I said, you need to go into hospital. Turned out he had an abscess in one of his thoracic spine. But if I hadn't done the blood test, that's how easy you'd miss it. Next thing, 70-year-old man, abdominal pain, diagnosed bowel tumor, waiting surgery. So this was after Christmas. Surgery was, we weren't doing any routine bloods, we weren't doing anything. And I was just quite relaxed in there. So he came in to me and says, hiya, Dr. Boland. He says, you know why I'm here? No, I have no idea why he'd come in, And I said, I says, how am I going to go around this? I says, how'd you get on over Christmas? He says, I got on fine. And I says, that's good. Oh, no, he says, I ended up in hospital. And I says, what'd you end up in the hospital? I said, I had chest pain. I went to the local hospital, did an ECG and did a chest x-ray, and they sent me home. Now, he hadn't told him that he'd been already diagnosed with a bowel tumor. So when he came into me, I thought, Jesus, this is a bowel tumor. Examine him. He was partially obstructed. But it was easy for me. He just was in. He'd been drinking over the Christmas and he wanted some Librium. Easy to miss. Again, 26-year-old man, 26-year-old man came into me 6 months ago, non-specific right maxillary pain, did a full examination on him, couldn't find anything. I said, look, this is my official pain, whatever, put him on an anti-inflammatory. He ended up with a dentist. He ended up a couple of places, and 3 months later he came back to me and a really malignant Ewing sarcoma of his maxilla. That is how easy it is to miss things in general practice. And in surgery, I'd be focused. I'm aware that anything comes into me, but that's how easy it is to miss stuff in general practice. And I believe every general practitioner has a guardian angel looking after him. It's the only way you can survive. Again, general practice. It's a highly organized system for delivering complex holistic care. It's fully computerized. It's proactive to the needs of the community it serves. It's a small, medium-sized business in every town and country. Unlike the HSE, there is no bailout for general practice. You've got to keep the business end of it right at the end of the year. We employ people. We provide our own premises. We are embedded in our communities, like the parish priest, the bank manager, GP. Parish priest is gone, bank manager is gone, online. The only thing that's left is the GP. We provide a critical and essential services to our communities. This is 24 hours a day, 7 days a week, 365 days a year. 21 million consultations done in practice last year. We provide all other services, the dentist and around, the social worker around, the guardist and around. No discrimination between public and private patients. Ireland, two healthcare system, private and public. You know, you have private healthcare system, it's easy to get into the system. No discrimination in general practice, no waiting list. We're comfortable with diagnostic uncertainty. There was a study linking diagnostic uncertainty with emotional exhaustion, job satisfaction, and intention to leave practice. So if you come into general practice and you're not able to cope with diagnostic uncertainty, find another career. We provide service from the cradle to the grave. It's a very personalized service with a doctor-patient relationship. GPs generally have excellent interpersonal and social skills, excellent at time management. How do you manage to get a patient in and out in 15 minutes? Define diagnosis, present differently, just like the 4 examples I've given you. It is the art and science of medicine. We have a sixth sense, and you live with your mistakes and perceived mistakes. So as I go through all those again, I'm feeling weak. Can someone come up and help me? That's all right. Okay. So if have a great weekend. If anyone asks you what are you going to do in general practice, any of the consultants here, your juniors are asking you, say what you're going to do in general practice is write prescriptions, refer people to outpatients, and anyone you don't know about, refer for a consultant opinion. Thank you very much.